Cardiology. Before any continues or starts, I wanted to mention Grand Rounds next week, because I seem to forget this at times, so I'll do it now. Next week is Dr. Keys is going to present neurologic diseases in famous composers. So I thought that would be, it sounds like fun. Anyway, Annie, please.
Thank you. Mine won't be as fun, though, so sorry ahead of time. Is this too loud? No? Okay. So there's been quite a lot of changes in cardiology in the last 3 years or so. And so I figured I'd do a little update on what's happened in the last 3 years. And hopefully most of this is now review for everyone, and maybe you guys are already implementing this in your practice. But at least it'll be a nice overview. But my main goal is to see if we can formulate a discussion with all the different subspecialties in terms of putting together all the different care that we provide as vascular medicine doctors to form a collaboration where we can officially obtain the one goal for our patient, which is to decrease subsequent cardiovascular events. So these are my disclosures. Now, as a cardiologist, I'll admit that we're very focused on the coronary arteries, but we really need to understand or appreciative that this vasculature is systemic. And so we really should be using the term atherosclerotic cardiovascular disease instead, or ASCVD. And basically it just means we're not only concerned about the coronary arteries, but also about the cerebral vasculature, the peripheral vasculature, and the renal vasculature as well. Now, to illustrate what I'm going to be talking about for the duration of this talk, I just want to use a case. I think this is a little bit close to my mouth. I want to illustrate a case so that we can kind of go back to it every so often and use it to guide us in our discussion. So this is a very typical patient that you guys might see overall in your practice, but a 65-year-old male comes in for a routine visit to see a family doctor. And the past medical history is significant for a prior MI, drug-loading stent to the mid-LAD back in 2012, a residual lesion in the D1, a 60% lesion in the proximal left circumflex, and a 50% lesion in the prox RCA as well. This patient has also had diabetes for the last 15 years, as well as hypertension and dyslipidemia. So pretty common patient that you guys will see on CTU as well in your clinical practice. Now, the medications that the patients are on, pretty optimal for what you would expect 5 years ago. So aspirin, full dose rosuvastatin, full dose ezetimibe, and ramipril for endovascular protection, and metformin for his diabetes. So it seems like he's pretty well controlled. And you ask him, so how are you? And he says, not much change. I'm doing about the same. And you specifically ask him more questions to make sure he doesn't have angina, he doesn't have heart failure symptoms, he doesn't have palpitations, no lightheadedness, no syncope. Question, no, 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 to answer each question, and no bleeding problems, he says. Now, he tells you, Doc, I've really taken your advice to heart. You told me to eat the Mediterranean diet. I do that now. I exercise regularly like you tell me to. I cut my waistline down to less than 40 inches. I'm good about drinking alcohol in moderation. As you know, I quit smoking years ago, and my stress management is good. So I'm doing really good lifestyle-wise as well. So you say great, and you move on to your physical exam, and you see that his BMI is a bit high, so 28. His blood pressure reasonable, 118/76. Heart rate is 78, clear lungs. He's euvolemic on exam, and his heart sounds are pretty normal. The only thing is you did detect that one of his pedal pulses, the left side, is a bit decreased. Now, in terms of your investigations, you look at his lab work, and you see that his renal function's good. You see that his A1C is 7.8%, his LDL is 2.6, and his ECG just shows evidence of a prior anteroseptal infarct with QAs in the anteroseptal leads. So for the astute physicians out there probably looking at those numbers, you've probably noticed that the A1C is a bit above target and that the LDL is above target as well, right? So today we're going to be talking about a patient similar to this and other patients who have an increased or ongoing residual risk of subsequent or an initial cardiac event or another cardiovascular event. And then we'll talk about how we can optimize the situation for patients like this to decrease the risk of another event. And then finally, I do want to explore how we can all work together within a vascular medicine network to really optimize our common goal. So we'll start with the first objective. Now, we've used the term stable CAD for a long time now, and as I mentioned earlier, we want to move on to this new term called ASCVD, or atherosclerotic cardiovascular disease. Now, stable ASCVD, well, how truly stable is this man? Now, unfortunately, we know that cardiovascular disease is still the leading cause of death worldwide. The World Health Organization, the last published data is from 2016, and it shows, I don't expect you to see this very clearly, but it does show at the very top, ischemic heart disease is the leading cause of death worldwide, and stroke is a distant second from that. But stroke is also the leading cause of morbidity worldwide as well. And the unfortunate truth is that we actually haven't moved on too much from back in 2000, when, again, it was ischemic heart disease and stroke as the top two leading causes of death. So these are still the reason why a lot of our patients are dying. And the reason is this: we've been calling things stable CAD, stable ASCVD, but we have to understand it's not so much a stable condition, it's a progressive condition, and it's a chronic condition that will get worse unless you modify the risk factors and modify the situation. And of course, as we go along, if our risk factors are not optimized, we'll form more plaque, possibly have a plaque rupture. If that's in the brain, that's a stroke. In the coronaries, that's an MI. In the peripheries, that's an acute limb ischemia. Now, if we were to take a bunch of all-comers with a prior MI and set them as a reference point of 1, we know that patients that have additional comorbidities above just having an MI actually have a higher risk of a subsequent event. So these are the patients with diabetes, the patients with renal impairment, the patients with heart failure and peripheral arterial disease. And if you actually have coronary involvement in more than one territory, so in double vessel disease or in triple vessel disease patients, that risk of a subsequent cardiovascular event is much higher. So that brings us to this question: what do we do for our patient? What can we do, and what should we do? So we'll talk about the literature on some of the novel approaches now we have for managing cardiac risk factors and also for managing ASCVD. Let's start with dyslipidemia management. So this will be a quick overview of what we'll talk about in this section. So dyslipidemia management, diabetes management, and also dual pathway inhibition and management of ASCVD. So let's start with the first one. Now, before we go on, I do want to show you this thing that I found extremely funny. This was an ad from the 1960s or 1970s. So back then, butter was advertised as being very good and good for you. So it's very slippery, which means it lubricates your arteries and your veins, and you should eat as much of it as possible. So we've come a long way from that because we know we can't just eat sticks of butter anymore. But back in the 1980s, they started forming this LDL hypothesis, sort of disproving that last theory wrong. And that looked at the data from a Mr. Fit trial, looking at how total cholesterol correlates with number of cardiac events, or specifically coronary heart deaths. And you can see that from that particular study back in 1986, that for every 1% increase in total cholesterol, there was an exponential increase in the curve, such that there was a 2% increase in the risk of coronary heart disease. But this is in 1986. Since then, there have been uncountable studies looking at how is this hypothesis true or not, and I can say it's not just a hypothesis anymore, it's a fact, the LDL fact, that the lower the cholesterol, the lower the LDL, the lower the risk of cardiovascular events. Now, secondary prevention versus primary prevention both have that same trajectory, for the lower being better, but obviously the primary prevention slope is a little bit less steep than that for the secondary prevention slope. Now, conclusion from a big meta-analysis looking at over 90,000 patients in total showed that for each 1 millimolar per liter decrease in LDL, there is an associated 21% reduction in MACE over 5 years. So MACE being a major adverse cardiac events. The traditional ones that we think about are cardiovascular death, non-fatal MI, non-fatal stroke. And in fact, if you get your LDL even lower, so below 1.9, there's actually been shown regression of the plaque burden based on the GLOGOF study. Now, we all know this, and we all know we should have our high-risk patients on a statin. And these high-risk patients are those with coronary disease, peripheral arterial disease, prior stroke, diabetes, and Framingham risk score that's 20% or higher. Now, what percentage of people do you think are actually at target, less than 2 for LDL, according to the 2016 guidelines? If you had to throw a number out there, how many people are at target for the high risk? Does anyone want to venture a guess? Is it over 80% of people are at target? Are we talking about 50% of people are at target? Yeah? Are we going to be pessimistic? How many people are below 50% are at target? Yeah. So unfortunately, that's the truth. Only 45% are actually at target. So that needs to be changed. Excuse me. And companies are looking for more and more, obviously, physicians are looking for more and more ways to tackle the LDL problem. And maybe it's compliance issues, maybe it's side effects, maybe it's difficult to remember to take medications. Whatever it is, there are numerous reasons why people are not at target. So the PCSK9 inhibitor story began basically back when they found a group of people, a genetic group of people with no or very little PCSK9 molecules, and they found that these patients were very, very low in their LDL and very low rate of MACE. And so they started developing PCSK9 inhibitors to see if we can replicate that situation. And I'll just run through what PCSK9 inhibitors do. Sorry if this is too much of a review, but if you look at the picture and looking at the left side of the picture, the A side, that would be the ideal situation. So the little purple structures are the LDL receptors on the surface of the hepatocytes. The big circles, the circular things are LDL particles, or represents the LDL particles. Now, if the LDL particle binds to the LDL receptor, that gets endocytosed into the hepatocytes, and that then gets degraded in the lysosome. And the LDL receptor is then recycled back over to the surface of the hepatocyte, where it can mop up more LDL particles. So that's the ideal situation. However, we do have PCSK9 molecules that are just produced in the endoplasmic reticulum in our cells, and if that is around, that will bind, or that can bind to the LDL receptor, and if that binds to the LDL particle, then the whole thing gets degraded in the lysosome so that the LDL receptor isn't recycled out to the hepatocytes. So it basically means if there's a lot of PCSK9 around, then that will decrease the amount of LDL receptors on the surface of the hepatocytes that can then mop up LDL particles. So if we inhibit those little red molecules there, the PCSK9, then we might actually have more of the A situation that you see in the diagram there. So one of the biggest studies that came out about PCSK9 inhibitors and outcomes in cardiovascular disease is the FOURIER Study, and that was looking at the PCSK9 Evolocumab, which significantly reduced the LDL in this population. So this population, there were 27,000 patients, just over that, with some sort of atherosclerotic disease. Either it was CAD or PAD or prior stroke, and usually with an additional risk factor. And these patients' LDL dropped compared to placebo from a median of 2.38 down to a median of 0.78. So with the Evolocumab, there was a 59% mean reduction in LDL, which is quite remarkable, and that drop happened very, very early on. Now, that can be great, that LDL comes down. What about hard endpoints? Would that be significant? And the answer is yes. So this particular study, the FOURIER study, looked at, as their primary endpoint, CV death, MI, stroke, unstable angina requiring hospitalization, and also coronary revascularization. And so in the red line represents the Evolocumab, or the PCSK9 inhibitor group, whereas the blue line represents the placebo group. And you can see there was a relative risk reduction of about 15% in that primary endpoint with Evolocumab, going out to about 3 years. Now, the more traditional MACE or endpoint that we usually look at, which is cardiovascular death, non-fatal MI, non-fatal stroke, is represented as this key secondary endpoint in the study, and there was also a very good separation with the Evolocumab group from the placebo group, about a 20% relative risk reduction. So the medication works, we know that. What about adverse effects? So if it works but people are getting side effects, it's still not an ideal drug. And the good news is that in this study they highlighted that the only significant adverse effect really was just injection site reactions. And for all the other possible adverse effects, there really wasn't too much of a difference between the treatment group and the placebo group. Now, people might get a bit worried about getting to too low of an LDL. And you'll see in your life lab reports, I hate this so much, but they'll say it's low and they'll mark it as abnormal. And patients get worried and they say my LDL is too low. But now we know the lower the better. And so that study, a sub-analysis was done using the population from the FOURIER study, looking at just how bad is an LDL that's really, really low. And about 500 people achieved an LDL of less than 0.26. And the median LDL was actually 0.18. So very, very low LDL. And you can see the people that got to an LDL less than 0.26 are represented in pink, whereas those with an LDL of greater than 2.6 are represented in red. And for cardiovascular efficacy, it was there. It definitely decreased the primary endpoint and the key secondary endpoint. But if you look at safety, there really wasn't a difference in the safety in terms of adverse effects between the patients whose LDL was really, really low, less than 0.26, and those with higher LDL. Goes to show that this is probably safe. Now, patients are most concerned about neurocognitive dysfunction or worsening on, with low LDL. And you'll see that in the Ebbinghaus study, which is also another derivative from the FOURIER study, that neurocognition was not affected at different ranges of LDL. So the different ranges are in different colors. Purple is the lowest, and that's less than 0.5 in the diagram there, and red is the highest at 2.6 LDL or greater. And you can see there was really no difference, no significant difference in terms of the neurocognition. Another PCSK9 study using Evolocumab, so another PCSK9 inhibitor, was the ODYSSEY outcome study, and that was published after the FOURIER study. And that also showed very similar results, so I won't belabor the info, but their primary endpoint was the reduction of coronary death, non-fatal MI, ischemic stroke, or unstable angina requiring hospitalization. And you'll also see that Evolocumab, which is represented in the red line, showed a marked decrease of about 50% relative risk reduction compared to placebo. And this is going out to 4 years. They had a longer follow-up time frame. So just from that little section that we just talked about, the summary is there is a very direct and linear relationship between LDL and CV outcomes. And we now have other ways of lowering LDL beyond what we previously could achieve with just statins, ezetimibe, niacin, and so forth. And that with a PCSK9 inhibitor, we can actually get levels very, very low and with no obvious or apparent adverse effects at an LDL level of even less than 0.5. So the lower the better for LDL. It's no longer a hypothesis, it's now a fact. All right, so let's encroach in on the endocrinologist's realm here and talk about diabetes. And it's important because of the new studies showing how certain antihyperglycemics have an effect on reducing cardiovascular events. I don't have to tell you guys in this audience, but we all know that cardiovascular disease is the leading cause of mortality in diabetics. So I won't go into that slide too much. Now, traditionally, our learning has been that microvascular complications are decreased the better you manage the diabetes, the more intense you get the A1C down to. But from a macrovascular perspective, for cardiovascular complications, cardiovascular mortality, in the previous large studies, and there were 4 of those, there really wasn't a significant decrease or improvement in either of those macrovascular outcomes. But that is until very recently when we started noticing that there are 2 specific classes of antihyperglycemics that have been shown to have cardiovascular benefit. So we'll talk about those. The first one is an SGLT2 inhibitor. And basically this, I won't go into the details, and really we don't know what the exact mechanism is, but we do have a lot of proposed mechanisms. But an SGLT2 inhibitor will increase the secretion or excretion of glucose in the urine. And that then leads to more diuresis, and effectively decreases preload, decreases myocardial stretch, improves blood pressure, improves perfusion to the kidneys, and that's mostly what the mode of action is for that medication. Now, GLP-1 receptor agonists, completely different, but this mainly works on inducing the glucose-dependent insulin secretion and also suppresses glucagon, and that's how it manages sugar. So this actually all came about back in, I think it was 2007, when rosiglitazone, one of the diabetic medications, was actually shown to have an increased risk of MACE, myocardial infarction, death, MI, cardiovascular death, and stroke. And so the FDA in the States and the EMA in Europe, they mandated that for all new diabetes medications that we have to prove that cardiovascularly they're safe. So they mandated CVOT or cardiovascular outcome studies to basically reassure that there are no increased or heightened cardiovascular adverse effects. And so one of the very first ones that came out that actually ended up showing cardiovascular benefit was the EMPA-REG outcome study, and that was looking at empagliflozin. So with empagliflozin, an SGLT2 inhibitor, they showed that empagliflozin was non-inferior in terms of cardiovascular events, but that it was superior for decreasing MACE, which for this study was cardiovascular death, MI, and stroke. And there was a decrease in about a relative risk reduction of 14% compared to placebo. I don't know if you can see this clearly, but the lines, the green line is empagliflozin, the treatment group, and then the gray line is the placebo group. Now that was mostly, the MACE was mostly driven by a reduction in CV death, and that was quite remarkable. Do the math here, about a 38% relative risk reduction. Now, as a secondary endpoint, heart failure hospitalization was also looked at, and that also showed quite a remarkable decrease as well of about 35% for patients on empagliflozin versus placebo. Another SGLT2 inhibitor, canagliflozin, that was studied in terms of a cardiovascular outcome study, CANVAS and CANVAS-R. So CANVAS-R was the renal component of CANVAS, which was the main study, and that in green compared to placebo in gray also showed a reduction in MACE, and again that was cardiovascular death, non-fatal MI, non-fatal stroke, and the reduction was about 14%. And I'll just run through these really quickly. The Credence study, this was more recent, and that looked at specific patients with renal disease. And I have to remind you, these are all diabetic patients so far that I'm talking about, diabetic patients. And the Credence study actually looked at the renal outcomes of patients on canagliflozin versus placebo. And they looked at renal outcomes in terms of progression to end-stage renal disease, doubling of their creatinine, cardiovascular death or renal death as their primary outcome. And the canagliflozin group, which is the blue line, did show a significant reduction in that primary endpoint compared to placebo, which is in the red line. But if you just look at the renal outcomes alone, so you exclude the cardiovascular death group, then there was also this remarkable reduction in the renal outcomes on canagliflozin. And these are patients whose GFR is generally around 60 to 90, so pretty big population. 50% of these people had CAD, and 50% of people just had diabetes and renal dysfunction without CAD. Now, I forgot to mention, but in the very first study, the empagliflozin EMPA-REG outcome study, 100% of those patients had established CAD, whereas in the second one that I talked about, CANVAS, about 67% of people had CAD, so secondary prevention, whereas dapagliflozin in the DECLARE TIMI 58 study looked at patients from both the secondary prevention group and also the primary prevention group, in that about 40% of patients had established cardiovascular disease and 60% did not. And they were just diabetics with high risk for cardiovascular disease. So in this study, their primary endpoint was a bit different from what we're traditionally used to, and that was cardiovascular death or heart failure hospitalization, a composite of those two. And that did show a significant difference, borderline 0.05. So my apologies, 0.005. So it was significant between the dapagliflozin group and the placebo group. But this was mostly driven by a reduction in heart failure hospitalization. But if you look at just the MACE alone, there was no significant change if you look at that as an individual endpoint. However, if you look at just the renal outcomes, then there was a significant reduction in the progression to end-stage renal disease and need for, say, renal replacement therapy, and also doubling of their creatinine. So we do see that in this population, mostly primary prevention patients, there really was a reduction or a benefit from a renal perspective. So let's shift gears and talk about the other class of antihyperglycemics that have also been shown to have cardiovascular benefit. And that is, we'll start with the LEADER trial, which is liraglutide. And that also was done just to show that cardiovascularly it's safe to use, but it did also show a superiority in reduction of CV death, non-fatal MI, and non-fatal stroke by about 13% in the liraglutide group compared with placebo. Semaglutide, once a week now, rather than once a day for liraglutide, was another GLP-1 receptor agonist that was studied in the SUSTAIN-6 study, and that also showed a 26% reduction in their primary endpoint, the traditional 3-point MACE. So just to summarize what I just quickly went over in terms of the studies, all four big studies, empagliflozin, canagliflozin, LEADER, and SUSTAIN-6 with liraglutide and semaglutide all showed a reduction in 3-point MACE. But only empagliflozin and liraglutide actually showed a decrease in cardiovascular death. Only SUSTAIN-6, which was semaglutide, showed a reduction in stroke. And only the SGLT2 inhibitor showed a reduction in heart failure hospitalization. But all of them showed some sort of renal protection or renal benefit. Now, which agent you choose will depend on a lot of different factors, but one of which is their baseline renal function. So you have to be careful about using a SGLT2 inhibitor for patients with baseline renal dysfunction. Now, this these studies have changed the diabetes guidelines in that second-line therapy now for patients with diabetes and established cardiovascular disease is now one of these agents, an SGLT2 inhibitor or a GLP-1 receptor agonist that have been shown to improve cardiovascular outcomes. And that would just be the tip of the iceberg, which you can see in this diagram as being just that top pink triangle there. And that's also because there was that reduction in MACE as well seen in those studies. But if you want to think sort of more broadly into the bigger picture of diabetics with risk factors for cardiovascular disease, knowing that cardiovascular disease is the leading cause of death, you might want to say, well, why don't we give them the benefit for a decrease in heart failure hospitalization and the benefit of protecting their kidneys, which is also one of the biggest complications of having diabetes. And maybe SGLT2 inhibitors and GLP-1 receptor agonists should be second line for that, for those people as well, even without established cardiovascular disease. And that was, as I mentioned, kind of seen in the dapagliflozin study, showing that even in the primary prevention patients, there was renal protection benefit and heart failure hospitalization decrease. Okay, so just to summarize that part, we do have certain antihyperglycemics now that have demonstrated cardiovascular outcomes or benefit and should be considered a second line in patients who are on metformin and not yet at target A1C for those with diabetes and established ASCVD, and possibly even in the patients without established ASCVD. Okay, so lastly, let's talk about dual pathway inhibition in terms of the direct management of ASCVD. So let's just go back to our case here. That same 65-year-old guy, maybe he's 66 now, but same history, but now he's on, based on what we've just talked about, now he's on Evolocumab, and now he's on empagliflozin. And now he's lost weight. Empagliflozin can result in some weight loss, so BMI is a bit better, blood pressure is a little bit lower than before and still at target below 120/80. Everything else looks the same, except his A1C is now at target and his LDL is now at target. So this guy's doing well. Are we happy with this? And the answer is we shouldn't be, because like I said, it's a chronic condition. It's a progressive condition. Atherosclerotic disease is a progression. And so there is still a residual benefit, even when we're meeting all the cardiac risk factor prevention targets. So this data here is from the Solid TIMI study, which looked at patients that are on recommended secondary prevention therapies, and for the most part meeting the targets, maybe not completely, but at least trying to meet targets, and they still have a 15% risk of cardiovascular death, MI, and stroke out at 3 years. And that's not low. That is a reminder that this is a progressive condition. Even if you're treating a lot of the risk factors, there's something else that might be brewing that we can potentially treat. And so with all this in mind, there have been numerous studies looking at different ways that we can optimize the risk of these patients, even beyond that of just modifying their risk factors. And so there have been studies looking at maybe changing aspirin to clopidogrel instead, or adding clopidogrel to aspirin, or adding ticagrelor to aspirin, or using something else, a thrombin receptor blocker, and adding that to aspirin. And although all of these studies, and there are many others too, did show a reduction in MACE a little bit, there was an unforgiving increased risk of bleeding, such that these have never really taken off, except in certain circumstances. And if you think about it, it does make sense, because if we're giving them more antiplatelets, we are really plateauing out at how many platelets we can inhibit, or how much of the platelet aggravation and activation we can inhibit. But thrombus formation isn't just about platelets. There's also a second arm, which is the coagulation aspect. And the coagulation cascade can lead to thrombus formation as well, in addition to the platelets being aggravated and leading to thrombus formation. So we need to tackle thrombus formation from both angles and not just the antiplatelet side. And with that in mind, there have been lots of other studies, mostly quite a while ago now, looking at using moderate to high intensity oral anticoagulants, so warfarin, which is what we had in the past, and seeing whether or not versus aspirin that would decrease cardiovascular events. Lots of studies. This here is a nice meta-analysis looking at a summary of all the studies. And although there was some reduction in MACE, there was also, again, a high risk of bleeding that didn't justify this strategy. So it's always this complex between bleeding and thrombosis that we're worried about and how to juggle between the two. So the next study that I'll talk about is the COMPASS study, which basically tries to address that issue by using an oral anticoagulant, rivaroxaban, but a lower dose. So instead of 20 milligrams or 15 milligrams once daily, it's 2.5 milligrams twice daily. And they looked at a huge population, 27,000 patients with CAD or PAD. And they found that if you were to use dual pathway inhibition, so that's with rivaroxaban plus aspirin, that you can decrease MACE compared to aspirin alone by a relative risk reduction of 24%. So that would be the black line versus the colors, that orange line, brown line, and that the separation occurs is actually quite quickly, quite early on, within even a few months of the study. In this particular study, they also looked at rivaroxaban alone without aspirin, and the dosage for that was 5 milligrams twice daily. And they did not see a huge difference compared with aspirin alone, so this isn't a strategy that we would use. But the dual pathway inhibition with rivaroxaban and aspirin did show a significant difference from aspirin alone. Now, if you like bar graphs instead, I put that in there for you. And even though there was a significant decrease in MACE, this was mostly driven by cardiovascular death and stroke. So the decrease in cardiovascular death was about 24%, and of stroke was about 42%. And that's actually quite a very remarkable number as well. Now, the reduction in MI was a trend towards a reduction, but not a significant reduction. Now, all that is great, but what about, again, the adverse effects? What about the bleeding risk? And absolutely, the bleeding goes up with the treatment group, which is the rivaroxaban plus aspirin group, compared to just aspirin alone. But the bleeding that matter, so the fatal bleeding and the intracranial hemorrhages that did not result in fatal bleeding, those two were not significantly different between the treatment groups. Between the treatment group and aspirin. And in fact, the all-cause mortality is actually lower in the dual pathway inhibition group compared to aspirin alone. And this was a pre-specified endpoint in terms of looking at all the potential negatives, which is the bleeding risk, and the potential positives, which is the decrease in MACE, and they called this the net clinical benefit, and they found that there was an improvement in the net clinical benefit of about 20%. So overall in favor of the benefits versus at the expense of the bleeding risk. Now, as I mentioned in the COMPASS study, they looked at CAD patients but also PAD patients, and the PAD patients as a different subgroup analysis showed also a decrease in MACE. So again, that's our traditional cardiovascular death, MI, stroke, and the dual pathway inhibition group actually did even better than the overall population of CAD and PAD by a reduction, and I think it's quite small here, 28% risk reduction. Now, they also introduced a new term in the study, the major adverse limb events, or MAIL, and that is basically the need for amputation or the need for revascularization of the peripheral arteries, and that in the dual pathway inhibition group also was decreased compared to the aspirin alone group. All right, so that said, who is that typical COMPASS patient? Well, it's basically that patient that I presented to you, someone with established atherosclerotic disease, either in the form of coronary artery disease or peripheral arterial disease or a prior stroke or TIA, or documentation of stenosis over 50% in any of those vascular beds. For the patients with coronary artery disease, they need to have multivessel disease either on CT imaging or of 50% or more, or they've had a prior PCI or prior CABG, and they're over age 65. If they're not over age 65, they need to have at least 2 additional risk factors to make them eligible. So these are high-risk patients, basically. And then same with the peripheral arterial disease and carotid artery disease patients. They need to have had some sort of an intervention or documentation of at least 50%. Now, who isn't a COMPASS patient? So because of that risk of bleeding, absolutely anyone with a high bleeding risk should not be a COMPASS patient, or anyone with a stroke within the last month because of the risk of hemorrhagic transformation, or symptomatic lacunar stroke because of the risk of cerebral hemorrhage as well in these patients. If they just had an incidental finding of an asymptomatic lacunar stroke that, that was just picked up on CT of the head or MRI of the brain, those patients are still eligible. Anyone with a prior cerebral hemorrhage or severe heart failure or severe kidney disease. Now, severe would be defined as an EF of less than 30% or NYHA class 3 or 4, and severe kidney disease would be defined as an EGFR of less than 15. Now, if they need an anticoagulant for another reason, or if they are on something other than aspirin as their antiplatelet strategy, these patients would not be a typical COMPASS patient. And also, I just added a few to their exclusion criteria, which is if someone has an anemia NYD and it's significant enough, I probably wouldn't feel comfortable not knowing where the source of bleeding is to start someone on rivaroxaban. If they have a huge aortic aneurysm, I might be a bit worried in that situation. If they're frail or if they have a need for concurrent NSAIDs, then I might be a bit more cautious in those groups. So I had mentioned earlier that if you have additional high-risk comorbidities, in addition to having just had an MI or established ASCVD, those patients have a much higher risk of a subsequent event. But it was also shown in this study that those patients in particular had more benefit to derive from dual pathway inhibition. So these are the patients with CAD and PAD, the patients with CAD and heart failure, that's not severe. So the EF is still 30% or higher, NYHA class 1 or 2. Or those patients with renal disease, that's not severe, so GFR over 15. These patients actually had benefit in terms of the dual pathway inhibition compared to aspirin alone. The bleeding risk is high, but not out of the ordinary for what you would expect from the overall population. Now, stroke patients in the COMPASS study was actually quite small. There were only, I think, 4% of patients with a prior stroke.
Code gray, lab information system. Code gray, lab information system. Code gray, lab information system.
Okay. So, but we do know from the COMPASS study that if you are in that 4% with a prior stroke and being enrolled in this study, that this is a very strong independent predictor of a subsequent stroke, which goes to show that this is a good mechanism or a good medication to consider in those patients. So the summary from that part of the study, of this talk, is that even if we're very good at secondary prevention, unfortunately there is still this high residual risk of cardiovascular events in these patients with stable chronic ASCVD, but we can consider dual pathway inhibition in these patients to try and lower that risk as long as they don't have a high risk of fatal bleeding. So that brings me to an overall discussion on vascular protection. So we have a lot of healthy lifestyles that we recommend patients. We have our standard or our current pharmacologic secondary prevention in terms of all our antihypertensives, our antidiabetic medications, our lipid-lowering agent, our aspirin, our clopidogrel, ticagrelor, prasugrel, and so forth. But we now have, on top of those traditional medications, novel or innovative pharmacologic methods to approach each of these risk factors. So in terms of antidiabetic agents, we now have the SGLT2 inhibitors, the GLP-1 receptor agonists. Antihypertensives, I put Arnie in there, but I really shouldn't have. We'll leave that to another talk. Lipid-lowering agents, that we have our PCSK9 inhibitors, and then in terms of dual pathway inhibition, we now have the rivaroxaban method as well of protecting the vasculature in these ASCVD patients. This is a good summary of sort of the reduction in MACE and specifically each independent endpoint for cardiovascular death, MI, stroke. And, you know, I'll just kind of breeze over this, but we now have a lot of these strategies that will help minimize the recurrent risk, the recurrent event. So lastly, I want to very quickly touch on a possible initiative that I'm hoping to get going here at St. Paul's and possibly involving the other region as well. But we are all vascular medicine doctors. Some of us are endocrinologists, some of us are lipidologists, some of us are internists and cardiologists, neurologists. Vascular surgery isn't here to represent, but we are all working towards a common goal, which is to decrease cardiovascular events in patients, and that could be protecting their limbs and preventing ischemic limb amputations. It can be preventing a subsequent stroke, preventing a subsequent MI. And we all have a role in doing that for our patients, but there is a care gap. For example, the very early PAD patients with mild claudication or mild PAD, maybe the severity isn't emphasized enough, but these are the patients that we can actually intervene on earlier so that they don't progress to getting a stroke and they don't progress to getting an MI. And even in the patients who've had a TIA or a stroke, and the neurologist might recommend, okay, get your LDL down and treat your diabetes and so forth, but sometimes they might just pass them along to the GPs who may not have the time or the effort, I guess, to lower to the target, which we now know we aren't very good at achieving LDL targets. There is definitely then room for improvement on all these optimization strategies and more aggressive medication management for these patients. And I really like the slide that I tweaked from you can see the reference there, but we are very good at treating patients after they have disease, after they've presented to a hospital with an MI. We can do tertiary prevention. We can prevent another event, or we can prevent complications. But we need to go one step down and detect early disease and start preventing at that level, which is secondary prevention. But even before that, we should be better at primary prevention, and these are the patients with just risk factors and preventing the risk factors from getting worse enough to develop atherosclerosis. But even before that, we should be even more encouraging of primordial prevention, which is making sure we don't even develop the risk factors in the first place. So there's all these steps that we can intervene at, and one of the biggest objectives wouldn't be primordial prevention or even primary prevention for this new vascular medicine initiative I want to talk about, but it would be really for the secondary and tertiary prevention patients where we know that they have atherosclerotic disease. It's established. But we can come together as a vascular medicine group to provide a long-term, multidisciplinary, but patient-centric shared care for these patients so that we can start with investigations, we can do optimization of their risk factors, even maybe consider dual pathway inhibition, but ultimately leading to maintenance and decreasing their outcome or negative outcomes and preventing a subsequent event. So the model of care would basically be the core physicians and internal medicine, cardiology, neurology, primary care being sort of the core for the patient journey, whereas the other physicians can help on the periphery for certain specific patients, and that can be the lipid clinic, the diabetes clinic, interventional radiology, vascular surgery, cardiac rehab, smoking cessation clinic, nephrology, and the hypertension clinic. So we can all come together to optimize that one common goal. Right, so just to summarize everything today, so unfortunately we do know that there is a high residual risk of cardiovascular events in our patients with chronic, not stable, chronic ASCVD, despite our efforts for secondary prevention. It is a linear relationship between LDL and cardiovascular outcomes, and there are no known adverse effects below an LDL of 0.5, which is now achievable with new novel agents. SGLT2 inhibitors, GLP-1 receptor agonists are anti-hyperglycemics with proven cardiovascular benefit and renal outcomes as well in these high-risk patients with diabetes and ASCVD, and should be second-line after metformin, and possibly even in the patients without ASCVD. Dual pathway inhibition with rivaroxaban vascular dose, 2.5 BID, plus aspirin can reduce cardiovascular events on top of just aspirin alone, including all-cause mortality. And then the last is we should all be coming together and forming a vascular medicine network or initiative to really combine all our expertise together and to really improve protection and prevention at every single level of that triangle I showed you. So with that, I'm happy to welcome any comments or questions.
Questions or comments? Questions, I guess. Any questions?
Can I maybe ask, you've presented a lot of data on secondary prevention, very little on primary prevention. Especially I was interested in this LDL story that you tell. Is there any studies they've looked at the general population, done studies in the general population to see, even if they haven't had any event yet,
Yeah.
they reduce the LDL, whether they can actually prevent events in the future?
Yeah, it's a very good question, and yes. So let me just scroll back a bit here. Yes, there are definitely a lot more secondary prevention trials, but there are primary prevention trials as well. And it's this one here showing that linearly there is also a correlation between lowering the LDL and cardiovascular outcomes, even in the primary prevention group. So it depends on the patient and age and gender and a lot of other things too. But as a whole, yes, there is that linear curve as well, or linear relationship.
Any other comments or questions?
So I've got a question. Great talk, Annie. So I thought your Mr. MI was a great representative case. So what do you do when you see him? Do you start all three at once, or do you pick one, and what do you pick first?
In terms of which one?
In terms of, do you start an SGLT2?
Oh.
Anything cost and coverage issues, do you start PCSK9 or SGLT2 or?
Yeah, so it sort of depends on the situation. I'll see which one is more heightened. So if it's the A1C that's 9%, I might go for that first. I tend to want to lower, if both are equivocal, so in this situation, the A1C was, I think I said 7.8% and the LDL was 2.6. I tend to want to lower the LDL more. I'm not sure if it's my training, but I know that with the hypothesis or the LDL fact, I would rather drive that LDL down and actually cause plaque regression if we can get the LDL low enough. So I would go with the PCSK9 inhibitor first. We'll have to talk to the patient, of course, because coverage can also be a problem as well. And if they can't afford that, and they have to pick the lesser of the evils, they might pick empagliflozin or liraglutide, which is a little bit cheaper. So it's going to be this conversation with each patient. If I had to choose, though, I would still optimize those two things prior to considering rivaroxaban.
Any other questions? What about inflammatory mediators as the basis for all of this?
Mm-hmm. Yes.
You didn't seem to touch on that.
No, I did have a slide, but I removed it. So you're talking about Canakinumab, or I can't pronounce it. Yeah, so inflammation is the source of all evils here, and absolutely decreasing inflammation is going to be beneficial. What recently was a study called COT, I think it's called, by looking at colchicine in decreasing inflammation and actually resulting in a decrease in cardiovascular events as well. It's not prime time for changing guidelines yet, but it is something that's intriguing and something that you'll probably see a lot more of in the future.
If there are no more questions, thank Annie for talking.
Great, thank you. Try not to look at you. Yeah, for sure.
Oh, they were all really good.
Oh, thank you.
No, good. That's great. I love that. No, super.
I'll send it to you.
Good job, Annie.
Oh, if I can't, because it's too big,
Yeah.
should I just, what's it called, Google, AirDrop? No.